Before beginning, explain the procedure to the patient. Inform him that you will provide topical anesthesia to reduce discomfort and that you will need his cooperation in swallowing while the tube is being advanced. Place an absorbent pad across the patient's chest and provide him with an emesis basin. Position him sitting upright in the bed. Place his head in the sniffing position, with the neck slightly flexed and the head slightly extended. Assess the patency of the nasal cavities by instructing the patient to inhale through each nostril individually and asking him if either provides better airflow. Visualize the nasal passageways with an otoscope to evaluate for septal deviation or other impediments to tube insertion. Choose the appropriate side for nasogastric intubation based upon these observations. Next, begin to prepare the nasal and oral mucosa. First, apply a vasoconstricting agent, such as oxymetazoline or phenylephrine, to the nasal mucosa. This often overlooked step not only reduces the incidence of iatrogenic epistaxis, but also increases the caliber of the nasal canal, which greatly facilitates tube insertion. In these endoscopic views of the nose, note that the administration of a vasoconstrictor shrinks the mucosa and creates a larger conduit for tube advancement. There are several options available for topical anesthesia. 4% lidocaine can be administered to the oral and nasal mucosa with an atomizer. The amount of lidocaine required is not established. However, 3 milliliters for the oropharynx and 1.5 milliliters for the nasopharynx should be adequate. Alternatively, 4 milliliters of 4% lidocaine can be administered via a nebulizer. Other options include topical benzocaine or hurricane spray for the oropharynx and viscous lidocaine for the nasal canal and nasopharynx. The type of topical anesthetic selected is not as important as meticulous attention to providing adequate anesthesia. Nasogastric intubation is a painful procedure, and proper anesthesia can substantially reduce patient distress. Next, prepare the nasogastric tube. The suction adapter supplied with the tube is often misplaced during preparation and tube placement, so it is beneficial to remove it from the nasogastric tube and insert it into the suction tubing prior to the procedure. Place the suction tubing behind the patient's pillow so that it is within easy reach once the tube has been inserted. Estimate the proper depth of insertion by measuring the distance from the xiphoid process to the ear and then to the nares. Note that black marks are inscribed on the tube for visual reference during tube advancement. Finally, lubricate the tip of the nasogastric tube either with viscous lidocaine or surgical jelly. Assure that the patient is sitting upright prior to inserting the tube. It may be beneficial to place your non-dominant hand behind the occiput to prevent the patient from suddenly pulling his head away. Carefully introduce the tip of the nasogastric tube into the selected nares and slowly advance it posteriorly, parallel to the floor of the nasal cavity. In this endoscopic view of the nose, note that advancing the tube superiorly will lead to a blind recess formed by the middle turbinate. Note that when the tube is withdrawn and redirected in the proper vector, it advances along the nasal floor underneath the inferior turbinate and on to the posterior nasopharynx. Tube insertion through the nasal cavity may be quite uncomfortable despite adequate anesthesia, and you may need to pause during insertion to allow the patient to rest. It is essential to advance the tube slowly during this portion of the procedure. Once the tube has entered into the posterior nasopharynx, less resistance will be felt and passage will be easier. Continue to advance the tube until it rests just above the larynx, which may be indicated by patient gagging or by a palpable resistance felt through the tube. Now you are ready to advance the tube into the esophagus. Enlist the help of an assistant to hold a cup of water with a straw for the patient. instruct the patient to begin to sip and swallow the water, and carefully coordinate advancement of the tube with the beginning of the swallowing mechanism. Rapidly insert the tube into the esophagus and stomach as the patient swallows to the predetermined depth. Correct timing of the advancement of the nasogastric tube is essential for successful completion of the procedure. In this fluoroscopic view, note that the nasogastric tube is resting at the level of the larynx. As the patient swallows, the tube is propelled into the esophagus and is then rapidly advanced into the stomach. In this endoscopic view, note that the trachea opens during inspiration and vocalization, and if the tube is inserted at this time, tracheal intubation is likely. When the patient swallows, the laryngeal apparatus rises and the epiglottis covers the glottis, preventing tracheal intubation and encouraging entry into the esophagus. First, assess proper tube placement by asking the patient to speak. Endotracheal intubation has likely occurred if he is unable to speak or has a newly hoarse voice, and the tube should be removed immediately. Next, auscultate over the epigastrium while infusing 30 milliliters of air into the tube with a catheter-tipped syringe. The presence of borborygmi suggests proper placement in the stomach. The same syringe can also be aspirated to check for return of gastric contents. The gold standard for confirmation of tube placement is chest radiography. If the nasogastric tube can be seen descending under the diaphragm, proper positioning is assured. Chest radiography is not mandatory after all nasogastric tube insertions, since the other methods may be accurate enough in certain clinical scenarios. However, if any substance is to be administered through the tube, such as activated charcoal or oral radiographic contrast media, obtaining a chest X-ray is highly recommended given the risk of accidentally infusing fluids into the lungs. After proper placement has been confirmed, attach the nasogastric tube to the suction tubing. Adjust the vacuum force to low or medium and set the control dial to the intermittent position. Finally, secure the tube to the patient's nose. First attach a piece of adhesive tape, ripped vertically 1/2 of its length, to the patient's nose. Then, wrap the tails of the tape in opposite directions around the tube.